Good evening, and welcome to our Meet the Maker series. My name is Ed Stever, and I'm the president of the NFOSD. I'm also a head and neck cancer survivor who was diagnosed with severe dysphagia in 2007 following extensive life-saving cancer treatment. Our goal with this series is to offer our community access to those who have creative products, specifically for people with a swallowing disorder. This series is intended to be informational, not promotional. We want to give you the opportunity to ask the creators of these products your questions. Learn more about how these products help people with swallowing difficulties, and make connections so that your voices feel appreciated among our industry partners. We thank you for joining us this evening and hope that you find this series helpful. Thank you also to those of you who donated with your registration or have become annual members. It is only with the financial support of our community that we continue to further our mission. The makers in this series have not paid to participate in the series, nor was it required that they be a past or current financial sponsor, although many companies, including Ampcare, have been prior financial sponsors of the foundation. If you participated in an NFOSD webinar previously, you are likely familiar with our process. You will be muted throughout the presentation, but we really encourage you to ask questions at any point using the question icon on the GoToWebinar panel. We've reserved about 30 minutes for Q&A during this broadcast, so please don't be shy about asking. We will record this presentation and make it available on our website within the next few days. And this one's important. There are no access CEUs provided, but you will receive a certificate of participation following the broadcast. With that, I want to provide a reminder that tonight's broadcast is for informational and education purposes. Both the NFOSD and tonight's speakers do not intend to provide any patient-specific diagnostic or treatment advice or recommendations. If you do need assistance identifying a swallowing specialist, please reach out to us via email. And now it is my pleasure to introduce Rick McHattie, speech language pathologist and vice president of Ampcare. Rick, you want to turn your camera on? Rick received his master's degree in speech language pathology from Texas Christian University and has worked primarily with the adult neurogenic population with a focus on dysphagia. Since the early 90s, Rick's research interests have centered on advancing methods for dysphagia treatment. Specifically, using skin surface electrical stimulation. He is the vice president and a co-founder of Ampcare. And with that, I will turn this over to Rick, who has volunteered graciously his time to present to our community this evening. Thank you, Rick. And, and I'm going to jump off. Rick will jump on, and he may have his work colleague, Russ Campbell, join with him later in the presentation. So, Rick, take it away. Thank you.
All right, Ed, thank you very much for your time and for the platform. So I can't thank you guys enough, and Elizabeth, of all that you do. So we appreciate this opportunity. Happy to provide the time to have this chat. Elizabeth, I guess you guys make sure everything is playing.
I'm in presenter mode. So if you want
to change that up.
Yep, and then we'll take it from there. And while you do that, I'm just going to remind people that in your toolbar, there's 3 handouts that you can download during this presentation. We'll make them available afterwards too. But feel free to download those during the talk. And then Rick, everything looks set on my end, so feel free to take it away. Thank you.
Awesome. Thank you guys. And it's going to be a little odd because I don't see myself, but that's okay. That's probably going to make it even better for me. As Ed said, I've been in this industry for a long time, and I feel some of the same, I guess, pressures and pain and needs, and my career kind of started that way. I'm going to throw this first slide up here, and I'm going to date myself. I recognize that, but then again, there's cartoon channels, so people may understand this. The way I looked at my tools, so to speak, for treating dysphagia when I got into this industry was back in 1991. When I met Russ Campbell and Rhonda Polonsky and I as SLPs, and Russ was in the hospital where we worked. And when we would work with patients in a standing frame, we got to have the opportunity to see Russ utilizing equipment plugged into the wall, electrodes all up and down, the legs, the arms. And Rhonda and I had our tools, which were what Russ and I joke about. It was elements of the earth. We had a piece of wood in the tongue depressor. We had a cup of ice. We had a laryngeal mirror, which I found was awesome because I could go to surgery and get it sterilized. And I felt very medical, let's put it that way. But as far as what I was doing from a treatment perspective, I didn't have a lot. I didn't have a lot of tools. So we joked that SLPs back in 91 were kind of the Flintstones as far as muscle rehab. It was kind of new. I had one lecture on dysphagia in my graduate program. So when I started into the industry, all of my education started to come from my mentors and from continuing education. So that became my passion to, number one, learn as much as I could. Even though the Joint Commission was the driving force behind me treating a patient in front of Russ, I think I know it changed my life. I know it's changed Russ, and we can cuss and discuss that, whether that's for the better or not. But I know for a fact it's changed a lot of patients' lives, because I really felt like I was working in quicksand, talking to patients about doing an effortful swallow, doing these strategies that they just really didn't understand. So when I saw what Russ was doing, and he and I had some discussions about how can I bring that to the SLP industry, I think what Russ had in his mind was, I'm going to show the next slide, and I'm by no means wanting you guys to read this to understand it, but I do want to make sure that as an audience, whether you're clinicians or whether you're patients or caregivers, when you hear the term electrical stimulation or E-stim, it's very common. This is what Russ thinks about. When Russ hears that, he's thinking, okay, how could I use interferential or Russian stim? Or how could I use high volt or NMES or TENS? So there's all of these ways to use this current, this electrical charge for therapeutic benefit, whether it's driving medication or whether it's working on swelling. But in our case, we're going to focus more on that NMES. And I think it's kind of cross paths with the term E-stim. Not all electrical stimulation is NMES, and NMES would mean neuromuscular, so it's nerve and muscle involved. And if you have the nerve and the muscle involved, you have some therapeutic benefit from the perspective of what the current and what the modality will do. So one of my main goals today is to differentiate using electrical current, like the tingling and the feeling, but we're going to demonstrate it more at that neuromuscular electrical stim, or NMES, and give you a true example of how it's used and how it can be used as an effortful swallowing exercise. So I'm going to show you the next slide. It's a video. I'm going to let it play. It's a wrist demonstration. And what I want you to recognize with this video, it's going to demonstrate what we can do to a wrist. So I want you to think, as you're seeing what Russ is going to do with the electrodes, to wrist extension, and then we're going to transfer that over into what does that look like for swallowing musculature and helping rehab the swallowing component. So let me get that video started and let you have a look. It's very short.
Okay, great. Carter feels tingling here at 5. 5 times 5 is 25. So here we go. Stim is on for 5 seconds, and then it's gonna go away. Carter, take as much as you can, the more the better. So I'm gonna go up about 3. So I went from 5 to 8. How does that feel?
It tickles.
Great. Can you take a little more?
Yeah.
The more the better. Here we go. So I'm gonna go up a little bit more. Whoa, look at that. Right in there. Got some movement. Did you do that, Carter? Carter didn't do that. All right, we're gonna let it run here for just a second. Get him to feel that 11, which is times 5, 55 milliamps. You didn't do that, right?
No.
Think you can take one more?
Yeah.
Watch what happens. We're gonna give him one more, and you're gonna see his hand go up a little bit higher. So what am I gonna tell Carter? Next time it comes on, Carter, work with it, hold it there, hold it there, hold it there 5 seconds, and relax. That's a task-specific, repetitive, resistive exercise for his wrist extensors. And now he's on 12. 12 times 5 is 60, and that's right where he should be for motor. So I leave him there, close this machine, and every time his wrist goes up, I tell him to hold it, hold it, hold it, hold it, and then relax. We good? Cool?
Yeah.
So just so you know that there's some science in there when he's talking about the multiplication, that's relating to the intensity, but I think you get an idea of the movement that can be created. If you were to visualize Carter in this example as having a paresis or no movement in that arm, I could verbally ask him to move his wrist extensor. And if nothing happens, I'm not going to get anything in return. But when you can use electrical stimulation and using it at a new NMES level, which means you're using it to a level of getting a muscle to contract, you can minimize some disuse and some atrophy that may happen with that extremity. So a little bit about us. So that left Russ and I with some really good ideas. We started some R&D. This was well before there were no modalities in this SLP range. I can remember when the nosy cups came out. We were all cutting the styrofoam cups, and I thought that was such a great idea. And I think that probably started my mind thinking, how can we do something for this discipline and for these patients? And so we started our due diligence and founded a company in 2007. This technology, and I think sometimes I think the technology has been in reverse. It's like speech pathology bringing something to physical therapy. I look more at this as like physical therapy is bringing something to speech pathology. There are 7 decades now of research for using electrical stimulation in all of those ways in that very complex chart that I showed. So we're taking a lot of that science and we're putting it on the neck and the face at such a level that it's, number 1, comfortable, but number 2, effective in delivering that current to get that therapeutic benefit. So we've been publishing, writing papers, having other groups work on research since '98. That was our first white paper that was written. Our goal is to continue that. We want to get a CPT code for the SLPs, and for those of you that are not in this country, it adds to some of the billable features within the modality that physical therapy and occupational therapists have. We obtained 2 FDA clearances for the treatment, and we have CE mark and MDSAP for some of the international guidelines and policies that we're working through for distribution. So 2007 to 13, that first 6-year plan, we got our patents issued. We registered ourselves with the FDA, got our FDA clearance actually on Halloween of 2013, and we launched our product, and we had a live training only for the SLPs. It was an 8-hour training. From 2014 to 2020, right up until the pandemic, we had some nice traction, had 2 phase 2 trials over in the UK. We launched our product in Hong Kong, UK, Japan, Ireland. We added the online training, and it was blind luck, but we added that the capability for all of the clinicians to train on our device and our program so that they can help their patients. And you can do it all online. You don't have to meet live. So especially during the pandemic, I think that saved us. From 21 until now, and our goals, we're in the process of launching to Middle East, Latin America, Turkey, Vietnam, and we've got our NMES as a treatment has been approved by the National Institutes of Clinical Excellence there with the physician's report that just recently happened in the UK and Ireland. And now we have a hybrid training where we can do some online and some live and actually take advantage of that hands-on capability. So what is NMES? And we hear this all the time in the literature. I've seen articles published that talk about whether NMES and then whatever the result, but if the parameters are not used to elicit a motor contraction, it's not truly NMES. It may have been the modality or a system that could provide NMES, but if it's not providing you with a motor contraction, it's really not being used as NMES. But if you electrically stimulate a nerve to get to that muscle contraction, you need that intact peripheral nerve, you can gain a therapeutic benefit from that. And that is our goal. And on the face and the neck, especially the neck and the submental region for dysphagia for the pharyngeal region, you should see a contraction. The most superficial musculature is the platysma. And if you're going to depolarize these nerves to get these muscles to contract, you will see a contraction. So what would that look like? And we can show you under just a visual of what that contraction may look like. Now, this patient, it's actually a clinician, it's not a patient, but this subject is tolerating an amount of current to depolarize the trigeminal nerve, which is going to contract. The anterior digastric and mylohyoid is going to facilitate that hyoid in that upward forward position. We're facilitating or helping that swallowing activity. I could verbally tell this subject, come on, I want you to really swallow hard or really move and do a Mendelssohn and hold that hyoid in an elevated state or hold that swallow. It's very difficult for patients to understand that in many occasions. What this technology does, if you can see that contraction, it's on for 5 seconds. And I think that's really important from the perspective of therapy and therapeutic benefit. You don't want to just contract a muscle and hold. You want to do it in repetitions, especially with the swallow, which is 1 to 1.5 seconds of time. So adding a few seconds to that for exertion, but then allowing for rest and recuperation, which is what you're seeing now. And then when the contraction starts back up, you'll even see the jaws trying to depress. And we have her hold her lips together, and we get even more anchoring of that hyoid. Now, that is neuromuscular electrical stimulation. That is the contraction that you should be able to see. Now, it's not hurting. You can see that she's smiling. So we're using parameters in the science that would support use on Band-Aid thin muscles. These are not much thicker than a Band-Aid you would put on your skin. They're not big, bulky muscles like my bicep or my quad. So we use a parameter that is very evenly tolerated, and it gets that contraction to occur. Now, science-wise, and for the clinicians out there, you're saying, so what? I've got this movement, but what do we do? The movement creates a stretching effect intrinsically. So we're pulling the hyoid forward and upward when the stem comes on, the 2 electrodes here, we're stretching open the laryngeal vestibule. And that intrinsic stretch puts the swallowing at a little bit of a disadvantage. It's the posterior pharynx trying to pull the hyoid back, or maybe the hyoid is trying to pull the posterior pharynx along with it. But when you create this intrinsic stretch, the goal of the therapy is to get an effortful swallow to occur. Swallow before the stem goes off, closing that laryngeal vestibule. And if we can create the stretch and the patient can overcome that stretch, then we can create an effortful swallow. And I think the audience as clinicians would say, what is our best therapy for swallowing? I know there are some things where we can do an extrinsic load and we can create this effort to the extrinsic neck musculature, but I'm going to show you a slide in a bit on neuroplasticity. And what we want to do is add as much as we can to the modality to support the neuroplasticity that is needed, especially for the neurologically impaired swallowing. We can create new pathways, but the only way to do that is to challenge those patients. So this is a still shot of what you just saw under X-ray. And so for those patients or caregivers that are on, this is just a side view of an X-ray picture. This is the hyoid, and just below that would be your Adam's apple or thyroid, your thyroid cartilage and the prominence there that you'll be able to manipulate or palpate. But when the stimulation comes on, I would just use this image for a patient to understand what is it you guys do at Ampcare. We create, this is 2 lines in this red line. When the stimulation comes on, it stretches open those 2 lines. And that stretching open creates an intrinsic stretch that they need to overcome with the swallow. And by overcoming that repetitively, you're making that patient do extra work, exertion. So I'm going to give you an example. If I had 20 backpacks sitting over here on the wall, and I ask any of you, can you pick up these 20 backpacks? And when you pick up the first one, you realize there's 50 pounds in the backpack. So it's fairly heavy for a backpack, and you lift it up and you put it on the table. You say, okay, I'm going to do 20 of those. Well, your first 10 you go through lifting up, maybe you lift your legs, you bend your knees, you do the proper lifting. You lift the bags up 50 pounds 10 times, and without you knowing it, the 11th bag has no weight in it. So I think you guys all can understand that when you pick up that bag expecting 50 pounds and it's not there, it's going to feel very light. And what that means is it wasn't a trick. It's just that those first 10 bags had exertion, they had weight, they had effort involved in them. And so we have some data, which I'll show you, that demonstrates this is an effortful swallowing exercise. We're going to simplify it to that. So the main reasons for using NMES are to increase strength. Now I'm gonna make a little statement here for the clinicians that are on here. It's not necessarily a strength problem. It's not because they're just weak. I think there's some good work Dr. Curry has in regards with MDTP and some of those exercises. We might build you up to a level that you feel like you could just swallow golf balls as a meal. That's not necessary for swallowing maintenance. And I can give you a couple of numbers. It's just for reference or for visual. If I can build you up to swallow at 70%, maybe 30% is what you need to sustain and eat 3 meals a day and sustain your nutrition and hydration. So we can build that. And that strength relationship also helps to build pathways through exertion and through effort, challenging the brain to learn something new. So it's not just strength, it is a learned skill. I hear the skill-based argument and the strength argument. If you had a stroke today and you have a swallowing problem tomorrow, it's not because you're weak that you're not able to elicit that swallow and get that going again. That's the skill, that's the loss of pathway. However, if you don't use that skill for a period of time, that's called disuse atrophy. And that is also one of the indications for use for this group. So you want to prevent that disuse by helping them facilitate some challenging swallows to increase range of motion and increase that muscle's function. Now, to that end, Ampcare's position, the submental, is for hyolaryngeal forward upward movement. Now, there are a lot of muscles involved with moving the hyoid and the larynx forward and upward. It just so happens that we can get to 2, maybe 3 of them here. And when we contract and pull that, facilitate that hyoid forward and upward, we are creating that intrinsic stretch. So we are also facilitating or helping that hyoid to move forward. And we're doing that repetitively. So let's look at some of the keys to neuroplasticity. It's very well known in exercise science, some of these principles. So let's look at it from the perspective of what Ampcare's effective swallowing protocol will do. You use it or lose it. If you don't use a muscle, you will lose that ability. If you just lay around and not walk and not do your exercises, you're going to get some weakness to that. So what we do is create an activity, even if they're having a hard time triggering a swallow, to come up with that facilitatory resistive exercise to help them along to minimize that disuse. We have a protocol in this system that will challenge them for 72 up to 90 reps in 30 minutes. It doesn't mean that you start off 100% accurate. We're building up to that. But I can tell you, if you will work towards that 60, 72 to 90 reps and all of them being effortful, you're going to have a better chance of remodeling those pathways that have been lost. We're going to have that intrinsic mechanical load, that intrinsic stretch to the larynx and the pharynx. The task specificity, there cannot be anything more task specific for a swallowing impairment than to pair it with a swallow. So I'm going to tell you, if you can make it effortful, make the brain really challenge itself to get it to occur, you're going to really help remodel that cortex and remodel that pathway for getting that ability to swallow to return. It's repetitive and effortful swallowing. That's meaningful. They understand what that exercise is. And by that, I mean, if you're just doing arm lifts or singing to try to get the swallow to occur, that may not be salient for them. We're going to make it difficult. We're going to have them overcome that intrinsic stretch. And then what we're seeing in the data, and we've seen it since 98, the effortful swallowing, those exercises do transfer to bolus swallowing in actual meals. So a couple of research slides that we'll go through. And just so you guys have an understanding of what we're doing, I'm doing a couple that I find beneficial for this technology from the perspective of exercise. It's not something as speech language pathologists we get a lot of training in, but I can tell you from the perspective of working with Russ in the physical therapy industry, creating this perturbation or creating this resistance type to the exercise needed to be demonstrated. So we took 9 healthy grad students at TCU. We had them do 3 swallows before we did any stimulation. No ESP was applied. And we measured. There's a system that we have access to now, which is fantastic. It's called the TIMS Medical is the company. TIMS MVP, it's the software that will allow us to measure temporal and spatial measurements. We can look at timing using milliseconds for how fast does a patient get their airway to close. And in this case, there were subjects. So we're going to have them do 3 swallows and measure approximately how, or on an average, how fast it takes them to close their larynx. And you can do this at a system that, for the clinicians out there, using that at 30 frames per second. You can tick that system along until the larynx is completely closed, and you note that time down. Then we did 10 repetitions, very similar to the backpack example. We had them do 10 repetitions where the stimulation would come on, that intrinsic stretch would occur, the subject would overcome that stretch with the swallow, and did 10 repetitions of that. We removed the stimulation and had the subjects do just 3 additional dry saliva swallows to measure how fast they are after doing the exercise. And so look at that as picking up that 11th backpack that had no weight in it. And what we were able to demonstrate was 39% faster laryngeal vestibule closure reaction time in normal subjects. Now, don't get me wrong. This isn't, it's not earth shattering from the perspective of a patient necessarily, but what it is and what it's very meaningful in that it is providing a resistance in the exercise. It's creating an effortful swallow. We can ask a patient to do a swallow and make it effortful all we want, but we don't know whether they're actually doing it or not. It's very difficult for us to capture that right musculature to know whether they're giving us the true effortful swallow. In this technology, what we're seeing is that is definitely an effortful swallow. You can, when you feel that as a clinician, you'll be able to feel that as well. So the research, this is one of the most recent publications. Actually, it was a presentation at ASHA this past year. I'm trying to remember, I think we were in Orlando, I believe, wherever we were, I can't remember. I believe that's accurate. Dr. Matthew Dummican, what was it? New Orleans. We were in New Orleans? Holy cow, that's amazing. Western Michigan University, Dr. Matthew Dummican, he looked at 16 stroke patients. He had them he measured every one of their swallows using the penetration aspiration scale. He also looked at LVC, or laryngeal vestibule closure, as well as hyoid bone movement. But in the 16 patients, of all of the swallows in fluoroscopy using the Rosenbeck penetration aspiration scale, 47% fell in that 3 to 8 level. So I would consider that in the atypical range. The 1 and 2, for all of those that are looking at this scale, 1 and 2 being in the normal range, 3 to 8 being more in that atypical or abnormal perspective from the characteristics of the swallow. We did 20 treatments of this technique of Ampcare's ESP, 20 sessions. It was either 3 days a week or 5 days a week, depending on what it was. But when they finished the 20 sessions, he then evaluated those same 16 patients, and from 170 swallows in the first pre-treatment, he was able to get up to 195 swallows. And of those 195 swallows, 89% fell within that normal 1 to 2 penetration aspiration scale, and only 11% fell in that atypical 3 to 8. So it's starting to demonstrate, we're demonstrating through clinical avenues here, benefits to the kinematic changes. We're all seeing the changes from diets, from the functional oral intake scale or the Rosenbeck penetration aspiration scale. What we are looking to do now is to quantify with kinematic measurements what is changing, what are we targeting. So this technique is a very targeted approach. And is that target making changes? Is it creating more movement of the hyoid? Is it creating more laryngeal vestibule closure as far as the speed? And we saw that again in this trial, from 280 milliseconds down to 210 with these stroke patients after therapy. So what is it? What is Ampcare's ESP? What is it that we do? It's a powered muscle stimulator, and it's with these electrodes, the E-series electrodes, and then it also has a posture device. ESP, the electrodes, the stimulator, and the posture device kind of help us in that acronym of effective swallowing protocol. But it's not just about what the box does. It's not just about what the electrodes do, and it's not just about posture. It's about all of those things and encompassing and incorporating all of those options. So we'll take one part of that device or this kit at a time. The powered muscle stimulator was the first stimulator cleared by the FDA. And if you can remember that first very complicated slide that had all of those settings in it from looking at the electrical stimulation parameters, what the FDA wants to see is that you remove some of those parameters that could be potentially damaging or harmful to a patient if used on the neck. And that is one of the indications for use that most of the traditional powered muscle stimulators have. There are some settings in there that may not be safe for use on the neck. So this device has been cleared for use on the neck. We have removed those settings to improve that safety mechanism, put that in place. There are multiple treatment settings, and those can be modified for more effort, for more challenging. So we give them an 80% rule in exercise physiology. If you work out and you make your goals, we want to be able to make it a little bit more difficult. And our parameters allow you to, since we can't add weight necessarily to the throat, we can add more repetitions. So that's one of the things that we do from the saliva swallows, is have them go from 60 to 72 to 90. And there are also some parameters that your head and neck cancer population that have that fibrosis from radiation, you might need some of those higher technology parameters to get depth to the current to help them, to get that range and get that movement. So that device was the first one with multiple parameters that you could use. Now the E-series electrodes, this is a very important part of what we did from Russ and mine, Rhonda's, I guess, research and ideas and preparation before we brought it to market. This is the most important because it's touching the patient's skin. This is what's delivering what our idea is. So we took very good care with that. We put the shape, if you put an electrode on the underside of your chin on the mandible, it will rattle your teeth. And you don't want that. It makes it very uncomfortable, where they would ask you to turn the system down. And if you turn the system down, you're not going to get motor. And now all you're doing is the sensory, which is part of the problem. But we want to add the sensory and motor. So we're going to disperse the current very evenly. We fan out the lead wires before we add these layers of conductive material, silver and carbon. and they're reusable. Even though we've taken that approach to put a lot of science in the design, we've made them industry standard, and that was important for us as a physical therapist. These electrodes are reusable up to 5 times, and then you throw them away and you get another pair. So you get, in one package of 2 pair, you're going to get 10 visits. So we wanted to make sure that that was industry standard. 2 placements, we do facial and submental. Those are very targeted approaches. You've got 3 muscles we can target here, 3 muscles on the face that we feel like we can target, and make that a very targeted approach and utilize that with your task-specific exercises. And then this electrode in its own right has its own FDA clearance. It is a class 2 medical device, and it is patented for that. And here's a dispersion plate, and I think this is important for everyone. If you look at the pie-shaped electrode of Ampcare on the left and the small traditional round, this is what's typically used in a lot of physical therapy, occupational therapy, but also most of the speech therapy electrical stim devices use this traditional round. If you just have a traditional round electrode and that lead wire goes right into the pad, you're going to have a high level of intense sensation at where the lead wire goes into that electrode. And when that gets really hot, it gives you this blue mark, which is indicating high current. When you take an electrode lead wire and fan it out so that there's different filaments going in different directions, you can make the same amount of current feel low current. It'll feel more in the yellow-green level. And that would allow you to use more current, to get more conduction, to get the contraction that I think you saw earlier. So that's important, I think, for us to get that NMES reaction from that nerve and that muscle. And the last part of the kit is the posture device. One of the things that we see a lot, for one start, you can use this as an extrinsic resistive exercise protocol, and the research demonstrates that. Dr. Chris Watts at TCU demonstrating that the chin to chest exercise into this brace doubles the amount of what a Shakir exercise would do, and that's just a head lift to gravity. We can double the amount of nerve conduction. You heat mold it to get it to your patient's position, and it will help maintain the electrode on the chin. Now, you can also maintain the proper placement of the patient. You see a lot of patients that are evaluated, you have to hold their head up to do the evaluation, and then their head goes back down. Well, then they go back to the facility or to the hospital and they're eating in a position that they weren't evaluated in. So this would allow you to properly position the patient, whether it's fees or the fluoroscopy, and be able to evaluate them. And then they could also use this at a low level, nothing mastication related, but if they are low level where they're using just liquids and some maybe semi-solids, that's reasonable to keep them in that elevated position to help them maintain proper posture, which I think is very much overlooked sometimes in our industry. And then the last thing we'll talk about is our training, and we provide 8 hours. That's advanced ASHA CE. We provide clinicians, and for those of you that are caregivers, this may be a question that comes out. This is a device that requires a physician's order. The clinician will come out, evaluate you as a patient or evaluate the patient to determine whether there's a mechanical impairment or a causation that would be treated by this technology. That's the reason for this training, to prepare them as clinicians and not just technicians. So it's not something you just hand over to the patient or the family and just have them do the buttons. There's a definite clinical approach to this system. We do it all online, we do it all live, or we have the 2 hybrid options where we can mix in some on-demand work. We can do some in a very much of a setting like you're looking at now, where you're looking at Russ or myself or Rhonda in an educational lecture, and then be able to have that live interaction via Zoom for questions. The last thing I want to show you is one brainstem stroke. That's some of our most difficult patients. This was 5 days in. They were placed with a peg. I think they went home at day 10. We had outpatient therapy started on day 23. They started Ampcare, and they were utilizing MDTP as well. And then after 2 months, they went to a FOIS level 7, which is the highest level of solids and diet you could have. Okay. I think if I'm right, I'm to the end of where I need to be, and I'll let anybody jump on here and tell me otherwise, but we're happy to circle up. I think we've got 30 minutes for questions. Is that correct? or something.
Yeah, thank you. I appreciate that. And Russ, you're welcome to join too, but we have several questions coming in, so I'll get started with that if that's okay with you, Rick.
Absolutely, please.
Well, thank you for that presentation. This is really great information for our community.
Thank you guys for all that you do for those of us that help these patients, and also what you do for those patients. So we really appreciate you guys providing us this opportunity. Should I keep my share going for now? I guess, is that all right?
Yes, you're welcome to keep your screen up. That there are a couple people that were interested in your contact information, so it's there on the screen. Feel free to contact the foundation too, and we can put you in touch with Rick and Russ too if you have questions, but we'll get started here. First question here from a couple different people. What is the ideal patient population that you see Ampcare being used with?
Yeah, I think the ideal patient population for us that we've seen in the research is the stroke patient. And I would say that if you're going to really limit that down to those with, obviously the lower amount of medical conditions. But when you have Dr. Shaheen Hamdi, you guys, I think, did some work with Phagenesis a couple of months back. Shaheen Hamdi has some work for the dominance and non-dominance of the motor cortex for swallowing. And because of that, I think when you have a stroke and you got that insult in the dominant hemisphere, what you typically see is a residual dysphagia. But when you do these task-specific, repetitive, resistive exercises and you create that challenge, you can make the non-dominant dominant, but they have to be challenged to do that. And I'm going to paraphrase, or not paraphrase, I'm going to clarify that a little bit more. The head and neck cancer patient population is another entity in and of itself. I think for us as SLPs and clinicians, it's very difficult for us to evaluate functionality. I think if we're looking at only penetration and aspiration as whether they were better or worse, it's potential that they would always have some penetration aspiration. So the functional improvement of the head neck radiation patient is long-term. I would consider it lifelong. I think you need to really work hard at a home exercise program and as much exercise as you can do. Otherwise, that radiation and fibrosis will get worse. And so that patient is different. So it's not like you do a set of exercises, say 20 or 30 visits, and then you reevaluate and yay, you're all finished. I think it's two different animals from that perspective of the fibrosis versus a neurological patient. So the long and short of that is a neurologically induced CVA related dysphagia would be the ideal. There are some additional one-offs from a lot of the different other populations. One that we do see now is the Parkinson's patient from diagnosis, I might add. So there's some prehab studies that are ongoing where they're starting some exercises from the diagnosis and not from the symptoms. If you can start working out and start benefiting from the exercise from the diagnosis, you can prolong when those symptoms start to occur. So that's a couple of the three that come to mind, Elizabeth, and let me know for us if that wasn't clear.
Oh, I think that was a great job. I think you did a good job. I would also recommend that you check out the handouts, the summary of evidence. There is an article by Dr. Nicola Martindale. It's in 2018. We give you a summary of anything that was ever published on Ampcare. And at the bottom, there's a link to that article, presentation, or poster. And I think this study by Dr. Nicola Martindale, she talks about the stroke patients. Obviously, Dr. Sprosen, or Lisa Sprosen, did a nice study, randomized control trial that was just stroke patients and found a benefit for sure. But then Dr. Martindale said, let's open this up, not just to stroke patients, but to the traumatic brain injury. We've seen some very nice results with the TBI population, but also had some other progressive neurological diseases in that, the Parkinson's patients. So take a look at that. And then I'd be remiss to say the video that Rick showed at the end, that wasn't from someone that we did. That was from a clinician who is trained in Ampcare, Cheryl Lopez, and presented this case study at FLASHA, the Florida Speech and Hearing Association. So I want to give her some kudos for that. Let her know that that was from her presentation.
Thank you, Rick and Russ. I appreciate that. Rick, to circle back to something that you had mentioned when you first answered that question, you had brought up phagenesis, and they were part of our Meet the Makers series previously this year, so there's probably quite a few people on our call that are familiar with that. But could you kind of explain the difference between what Ampcare provides and phagenesis provides, and if there's any research on the difference in outcomes with those two different treatments?
So I can't speak to the outcomes on their side. I can tell you the difference in how the two technologies work. I think I'm okay to say they're not NMES, and I think sometimes even the transcranial magnetic stimulation, sometimes they're all in our discipline. We're lumping all of these things as NMES. NMES triggers a nerve, depolarizes a nerve to get the muscle to contract. My understanding, and I'm by no means an expert in the phagenesis community, but I've known them for a while. And the work that they're doing is more sensory driven to the posterior pharynx to help wake up that neuroplastic effect. So 5 hertz, and this will give you some of the numbers. I don't know how much it will help if you understand the science, but 5 hertz on the posterior pharynx for 10 minutes versus 30 hertz, and that's just pulses per second, directly related to the muscles related to hyolaryngeal elevation. So they very much could, I guess they could corroborate together. So they're different as far as indications for use. One is on a catheter, on an NG tube on the posterior pharynx, and I'm pretty sure it's 10 minutes of constant stim. It might pulse a little bit there, but it's much lower to the posterior pharynx, where I think what you saw with us is we're putting electrodes directly on some functional impairment that has been lost, and that is decreased laryngeal elevation. So those are two primary differences, as opposed to the research. Everything's still coming out from that perspective on their technology. So I don't know what the results would show. I think they were doing some work for not only the trach patients, but also the stroke patients. So I don't know, Russ, if you want to add anything to that, but there's definite difference. We're not both NMES. I think that's one thing that I would want to clarify.
Yeah, I think certainly you want to understand that that is an internal type of an electrical stimulation. This is done inside the throat to the pharyngeal wall per se, right? So this is an implant, or not implanted, it's an internal stimulation from an NG tube that's stimulating the back of the throat. And it's sensory stim. It's more of a passive, let's try to wake up the afferent pathways from the throat to the brain. So the difference is that that's a big one. And then we are extrinsic. We are on the surface of the skin, which is what we would call transcutaneous. And we're not just sensory. Obviously, when you saw that video of us putting electrical stimulation in the form of NMES on someone's forearm, we're not only stimulating that sensory pathway afferently to the brain, but we're also eliciting an efferent motor. And the swallow is about both. It's about sensory, timing, initiation, and about movement. So we want to work both of those pathways. So I think that's a very big difference. Neuroplasticity can occur through both. But it occurs, in our opinion, a whole lot more when you get the sensory afferent along with the motor efferent. And I think that's probably the biggest difference. And this is good old-fashioned rehab. This is recruiting more muscle fibers than the patient can do on their own. Ampcare has got the 70 years of research that we used on skeletal muscles in physical and occupational therapy that we're bringing to the SLP discipline. And I want to make no doubt about it. We're a 30-minute treatment, and we're going to do this. It can be 10 visits. It can be 15 visits on 30 visits. It's just based on working and improving timing, initiation, and strength, where that internal placement is more of a sensory approach. Initial step study was 3 visits over 10 days, and now I think it's gone up to 3 to 6 visits.
I think it's 3 days, 3 days for 10 minutes, not 10 days, I think.
Oh, I'm sorry. If I said 10 days, I was wrong. It's 3
treatments for 10 minutes initially and then progress to 3 to 6 for 10 minutes.
But I mean, we're all doing, you know, I think our discipline, Elizabeth, you being one of us as well, you know, I compare all of these modalities that are coming along the industry, and Ed mentioned this at the very beginning. We're happy to support. Industry grows medical settings. When you have industry that is successful to the patient, that helps the industry grow and that helps the patient benefit. So all of these things, it's like, for some reason, I think sometimes the SLP wants one. They want one thing, and all these other things, not only that, I want one. It's like a neurologist wanting, I want just my CT scan. I don't want my MRI. I don't want my EEG. There's reasons and benefits to all of it. So, you know, I think it's fascinating for us to be able to grow our industry. I think it's awesome.
And while we should expect that all speech pathologists that are using Ampcare, along with any type of treatment, are competent in what they are doing, are there any adverse effects of using Ampcare if it's being misused, and what could those be?
Yeah, so
contraindications as well.
Yeah, I think I actually saw that on one of the registrations as well, Elizabeth, on they're already VitalStim certified, can they already use this? And that's the reason why, like to your point, we want you competent in being a clinician with this modality. This modality is absolutely a lot. It's mainly different. It's the opposite difference of what VitalStim would be used as. So yeah, we definitely need to train you on those adverse events and potentials. We don't use a bolus. You may have seen that when the stimulation is on with Ampcare because of that stretching of the laryngeal vestibule. We do dry saliva swallows.
Can you explain, Rick, sorry to interrupt, what that means to say you don't use a bolus? What does that mean for patients?
Okay, great, thank you. Yeah, so that's probably not clear. So we don't have anything of substance. We don't eat foods or drink liquids when you're doing the exercise. Now that's the 5-second exercise. Let me be clear. You can pause the device and do, for example, MDTP, which is a treatment that uses food as resistance and weight. You're going to definitely need to do that during this session by either ice chips or something that they're safe with. But when you're doing this exercise, and I mean during that 5 seconds of stimulation, we just do that with the saliva swallow. We don't want to compromise an already compromised patient. So doing just what we consider in clinical dry swallow, or maybe for everyone, a saliva swallow. We do that saliva swallow when the stimulation is on. If we pause the system or in your rest times, you can do the bolus trials. But this exercise on, and it's complicated, and hopefully I'm making sense by saying this. You don't use the foods or liquids when the stimulation is literally on and contracting. Hopefully that helps. And you mentioned the adverse events. There are some implanted electronic medical devices, active neoplasm or cancer or infection in the treatment areas. Electrical stimulation, NMES, will grow and increase blood flow, so you could potentially grow tumors that were in the area if they're still viable. So you want to make sure that they're cancer-free. And there's a significant part of that, and that is a very significant part of the training. The pacemakers and defibrillators, they require some extensive workarounds, including the cardiologist, potentially including some of the manufacturer's reps, as well as the patient on that. And then it becomes, you know, risk reward on that from the clinical decision making.
Excellent.
Did that make sense? For Elizabeth, I want to know if it made sense to her on when we do or don't, because sometimes that's kind of, oh, I want to use a bolus. Well, you can, you just don't do it when the stimulation is on.
Yes, and I think that's important too for everybody on the call to understand, is that you're not eating and drinking while doing that.
Right.
But you could do that in between those exercises.
I encourage it, because you're going to get dry. Even the people that can't control their saliva will become parched. So yeah, we definitely we train on that for sure.
How can people find somebody that's certified in Ampcare, and what percentage of speech pathologists are trained in this modality, would you say, that are treating dysphagia?
Yeah, I think that's a really good question. I would say there's probably less than 5% of the market right now, or right at it, of our medical speech language pathologists have trained with us in facilities, and that's growing. I don't know why. I mean, I think people jump on board with something that has some support, and the more support we do, and as a company, we're certainly going to do that. people are becoming more aware of what we do. I think on the registrations, a lot of people weren't aware of us, but we're clinicians first. I can tell you that. We're not some corporation, we're, I don't know if I'd ever want to be the big corporation, but from 2 clinicians or 3 clinicians, 2 SLPs and 1 PT. So as the 3 of us trying to make an impact in this world, I mean, we're trying to get the word out. Hopefully that's helping. You had some other part of that question that I'm blanking on now. How do they find them? There's a provider link on our website, but I can tell you if it's anyone who's interested in finding, if you don't see anyone on our provider list, not all of our providers are on that provider link yet. That's a fairly new, I'd say within the year addition. And so if you reach out to us, I can reach out and put you in touch with some clinicians that are trained in the area. I will also say this, if it's a clinician or a caregiver or a patient, it's not hard for a clinician who's seeing a patient to get trained. It's not, you know what I mean? It's not like you've got to go to Chicago and you live in Miami. It's very easily done. And Russ and I and Rhonda, we look at this from the perspective of we're a family. And so when you train with us, we're here to support you. And we take a lot of those calls. So we're happy to put you in touch with the provider. The provider should be on that list. If they're not, we'll help you out with that.
Perfect. And do you have tools or resources to help clinicians advocate for getting this type of training and then getting the tools too? There's a cost. I'm sure you're familiar with this question.
Absolutely,
how much is the budget to get this in our facility?
I'll tell you this, and there's nothing more expensive than something that doesn't work. And so if you're spinning your wheels, and we have a little ad on that, and that's just how I felt. If you're doing nothing and you're billing your codes and it's not working, there's nothing for a healthcare system to tolerate than something that's just not working. So now you're doing something for nothing. So we have a very extensive certified users page once you're trained. And on that, there is a physician education piece, which I find very beneficial for them. They can do as much as a QR code and watch some video content, or just some nice short infographic information to let them know. From a physiatrist or from a physician's perspective, Russ's industry of physical therapy, that's very well understood. So the directors and some of the DORs, I would call them directors of rehab, and some of the people in our gateway to get what we need as products as SLPs, luckily some of them, or a lot of them, are PTs and OTs that have been trained in this modality. So we're always happy to take on that for you, have the discussions with their decision makers, because between Russ and I and Rhonda, we can cover between the PT, OT, and speech world, and we know how productivity is for all of our clinicians. The last thing they want to do is go, take a basic 30-minute call into trying to get something. So we're definitely available to help with that. But yeah, there are some pieces on there, and the science is there. That's the other thing. You're not having to, get them to buy something that's not very well science driven. So that also helps.
Thank you. I want to be mindful of our time. We're approaching the top of the hour, but we do have several people living with dysphagia on our call, and caregivers as well. And so there's always a few questions of could this potentially help me? So maybe with a yes or no, and I'm sure there's lots of caveats to this, but do you know of cases where people with anoxic brain injury, years post-injury, have seen improvements using Ampcare?
The long and short is yes. And I'm going to give you, and I'm not telling you by every means, when you say some success, that's why I think I could say yes. I have a personal connection to some family on 2 different occasions that have had that. One was, both of them were anoxic episodes. And I know from continued support and continued rehab, you do see the progress. It's not fast. It slows down significantly, but that's not a give up scenario. So yeah, I think you've got to utilize everything to challenge yourself to get better. And it's when you start to maybe go from 5 days a week to 3 days a week to maybe just some maintenance as a patient. And if it's a caregiver asking, and if it's a caregiver asking to maintain that level of home exercise programs, maintain that level of activity. If it's a patient asking the same thing, I have a very close family member with anoxia, and so it's long and slow. there are continual advances. So, and yeah, there's always caveats. I'm not saying you go from, 0 to 100 from that perspective of functionality, but progress is slow and can be made.
Thank you. And similarly, any chance it could help improve esophageal dysphagia if somebody has something like esophageal dysmotility, any
So
chance there?
we are no farther than thoughts on that right now from the perspective of this technology, but I can tell you there are clinicians that are working very diligently in the esophageal region with manometry. So there may be some capabilities that we can add some stimulus to those cathodes and anodes within that catheter to help with that. But right now, I'm telling you, is no more than a thought from their questions where we are with it. However, I would say this, that if they are, look for someone who's specializing in high resolution manometry. That could be from the speech language pathology community or from the ENT or gastroenterology community for a good further assessment on what it is that's truly going on esophageal wise. There are a lot of new diagnoses that are out. There's a lot of new treatments that are coming. So I don't know what the esophageal pathology would be that this question's based on, but certainly stay in touch, because that's like you said, like I was saying at the beginning, we're working with ideas on that right now, nothing more than just the ideas.
Fantastic. Thank you for sharing that. There are some more questions that came in that we don't have a chance to get to tonight, but I will send you a list of all of those questions and the contact information for those who sent them. If there are other questions that we didn't get to, please feel free to reach out directly to Rick and Russ, or you can reach out to the foundation and we will forward those along. But we thank you, Rick and Russ, thank you both for being here tonight and for sharing more information about Ampcare. It's much appreciated. We had a lot of engagement, a lot of questions that we didn't have a chance to get to. But with that, we will wrap things up for the evening. We have people joining us from around the globe, where it might be the middle of the night right now, and getting late in the United States as well.
Yep.
With that, I want to let people know that we have our next webinar as part of our TED Talk series. It'll be on Wednesday, August 30th, and it's presented by laryngologist Dr. Shuman Dar, and he's going to be talking about Zenker's diverticulum. This presentation is geared towards people living with dysphagia and also caregivers, but also the healthcare community as well. So speech pathologists, physicians, everybody is welcome to join us for that. I will send out more information after this, and I'll also be sending out just a very brief survey. There's 4 questions to it. It takes less than 2 minutes to respond to that. We really appreciate any feedback that you share with us. It helps us guide our future presentations, and we also share this feedback with Rick and Russ too. So please feel free to fill out that survey and reach out if there's any questions, and we hope to see you for our next presentation. And with that, again, Rick and Russ, thank you so much for being here.
Thank you guys very much, and thank everyone for attending and for your questions. And contact us is at the bottom of our website. You can certainly send us an email there.
Beautiful.
Thank you, Elizabeth, Ed. Thank you all very much. Keep up the great work and hope to see you guys soon.
Thanks. Same to you. Appreciate it.
Cheers.
Bye, everybody.
Bye-bye.